On behalf of the authors, I would like to thank the ACP for the opportunity to present this learning case report and review of the management of Kartagener syndrome in the adult population. Primary ciliary dyskinesia is an inherited autosomal recessive disease involving defective embryonic cilia preventing the normal migration of internal structures. Kartagener syndrome is a subset of this disease and involves a triad of dextrocardia, bronchiectasis, and chronic sinusitis. There is significant variation in the clinical presentation of patients with Kartagener syndrome, with the most common manifestation being respiratory disease with repeated upper respiratory tract infections. Diagnosis, however, is often made incidentally with imaging that reveals situs inversus. Situs inversus typically occurs as a total reversal of the entire cardiovascular system and other internal structures such as the stomach and diaphragm. This poses a particular challenge in patients being evaluated for procedures, as additional imaging and pre-procedure planning is required. Of note, there is no cure for Kartagener syndrome. Thus, all treatment primarily focuses on symptom management and prevention of complications. The presented patient is a 78-year-old gentleman with a known diagnosis of Kartagener syndrome with dextrocardia, bronchiectasis, and chronic sinusitis complicated by frequent episodes of shortness of breath and productive cough. In addition, he has heart failure with reduced ejection fraction of 45%, bradycardia, and severe premature ventricular contraction burden, and underwent cardiac evaluation by the electrophysiology team for management of his PVCs. The patient's initial cardiac workup involved an EKG with standard lead placement as seen in Figure 1, which demonstrated positive P and R waves in lead 1 and AVR, along with right axis deviation and reverse R wave progression. A repeat EKG with reverse positioning of the leads produced a normal appearing EKG with first degree AV block and significant PVC burden as seen in Figure 2. A chest X-ray was also performed at this time, demonstrating dextrocardia, a right aortic arch, and right stomach positioning, as seen in Figure 3. The patient then completed a cardiac CT with 3D reconstruction, demonstrating reversal of the thoracic and abdominal organs, as seen in Figure 4. The patient then underwent home Holter event monitoring, which revealed a notable PVC burden of about 25%, an average heart rate of 57 beats per minute, and first-degree AV block. The patient reported feeling many, quote, double beats, but did not have any symptoms of lightheadedness, dizziness, presyncope, or syncope. The patient's PVCs were initially managed with metoprolol succinate, which reduced his symptoms to a degree. The patient was then evaluated for cardiac catheterization with pacemaker placement and radiofrequency ablation for his PVCs using a right-sided reversal procedure. This included CT imaging of the thorax and coronary angiography. Ultimately, however, the patient elected for medical management alone. Due to the increased use of genetic testing, imaging, and diagnostic measures, Kartagener syndrome is diagnosed at progressively younger ages. It is now supremely rare to diagnose adults with Kartagener syndrome in the United States unless they have immigrated at an older age. Additionally, as medical understanding and management of Kartagener syndrome improves, the life expectancy of these individuals is near that of the general population. Thus, management of Kartagener syndrome in the adult and elderly population is becoming more common. Management of the respiratory symptoms in Kartagener syndrome resembles that of cystic fibrosis to a degree. Prophylactic treatment of respiratory tract infections with azithromycin is recommended. Patients typically require daily chest physiotherapy to assist with secretions and mucus plug clearance in the absence of normal ciliary function. Several trials have also demonstrated efficacy of inhaled tobramycin in the prevention of Pseudomonas infections. Patients should have routine follow-up with primary care and regular PFTs and chest X-rays to measure lung function. In conclusion, Kartagener syndrome is a relatively rare disorder involving the triad of dextrocardia, bronchiectasis, and chronic sinusitis. Patients will require additional cardiac workup for any cardiovascular procedures, such as with this patient. Lastly, patients will likely need chronic daily therapy. However, overall, outcomes are generally very good in this population. Thank you for your time and consideration.